I am here with Yoshi Mitsuyama. He is a PRI trained guy. I don't even know what your role is, really. You got lots of roles. Um, but has a really good background in concussion management with his history, and he'll talk about that a little bit. But I just wanted to sit down because we can kind of relate this. What is it that we do for people with concussions that's different and hopefully more helpful for people and because we see people that slip through the cracks a lot, right? So, we talked yesterday at our staff, conversation the other day is that we don't see a lot of people for concussions, but we see a lot of people who have concussions. And there's a different way to manage people that have had concussions versus trying to actually treat a concussion. So, so Yoshi, why don't you just tell us like your background, like you have a big background in the world of high level soccer playing and have seen a lot of people with acute concussions and also people in chronic concussion states, and kind of just what gives you I don't know, some expertise in this area so we can sit down and chat.
Yeah, so I've been doing my I guess official credential as a certified athletic trainer.
Yeah.
My career's being always associated with soccer, and I'm passionate about it. And I spent several years in a professional soccer to see what these people really doing, and that was really my dream of why I came to this country to study about medical things. And I saw a lot of good things about soccer, and it's good to be in there to see that excitement,
Right.
what requires for these guys to be able to perform in a high level consistently is always my passion to know more.
Right.
And you get into that environment, there's a lot of pressures and all that stuff. But right now, currently, I am more like a consulting base to the each players rather than associating with particular teams.
With the team, and we'll probably get into how that is helpful for you and helpful for the players and
Yeah,
the pros and the cons behind it. There's a reason why you like to be more in that consultant role rather than
yes,
with the team.
yes.
But
There's a lot of red tapes. Yes, but
yeah.
yeah. So what I do is consulting based, and also see. Consulting based for professional athletes or just a normal clients, general population. In terms of concussions, like Torin said, that it usually by the time they come see me, they're not like in acute phase anymore.
Yeah.
They chronic issues that no one can solve. They hop around a lot of different places, and then finally found us. When I was in professional team and actually physically associate with them, then I saw a lot of
Well, more the acute phase. Yeah.
acute phase on the field or stretch them out, spine board, go to the hospital, all these, traditional conventional approach to how to get them back to the field as soon as possible safely. That was my job.
Yeah.
Yeah.
So which is something that we don't have a lot of experience with what we do in the clinic. So from that kind of perspective, how what's the biggest thing that you would see right away with somebody with a concussion? Say you have an athlete, they have a concussion. They're first of all, they have to get a diagnosis. So what's that process look like, and what does that kind of lead into?
Yeah, so if something happens in, let's say in a game, someone claps on the field, head-to-head contact, that's automatic. People go on the field, and if they're unconscious, so okay, I'll rephrase it. There are a lot of people looking at things from the top of the stadium right now that tells us really what happened, because in the ground level, sometimes it's hard to see in the same way.
Exactly
So
what happened.
top can really see better than what we see. So there's a microphone and all that stuff going on that they tell you, hey, you gotta stretch it out, and then they call it EMS, and all sorts of stuff is happening. But usually, if it's bad enough, we will take it to the EMS and in the hospital right away. If not, we have this thing called in soccer level right now. We have this thing called concussion substitutions. So when we determine or our doctor determine, yeah, you're concussed, you can do the substitution, but that doesn't use up your normal substitutions.
Okay, so it doesn't affect the strategy of the game necessarily.
Doesn't, so that taking out the strategy or a coaching staff, telling us,
Oh no, they got to stay in because I don't have any chance.
yeah,
Yeah,
and then they're heated up and in this, 40,000 people yelling at and all that. That kind of takes away
it's that pressure. No,
Yeah.
so there's some benefit to that to hopefully to protect the player a little bit.
But protect the player in that sense, that's very good.
Yeah.
So that would happen. So two scenarios: you completely out, go to hospital. You are out and you get subbed out, and then go into the room and then get evaluated.
Get evaluated there. So what's the process to get an actual concussion diagnosis? I know Ann's one of our PTs here. She said she knows she's had 8 or 9 concussions and has never been diagnosed officially with one because when she wasn't on the field during this a professional sporting event, right?
So if you go to the ER or something like that, they will just do all sorts of tests, right? MRI, CT scan, and all that stuff.
Right.
Clinically, I think the protocol is to basically do the impact test and then neuropsych testing to determine you're cognitively, I guess,
different.
The different than the baseline test.
Yeah.
Will determine these people, medical provider, to diagnose you as a concussion because there's no really objective way in scans or anything like that to show. If you see something in a scan, well, you got different problem.
That's all. Yeah. So as long as the scan looks okay, they say, well, you're clear. It's fine. You're right.
Yeah, you're not dying, so you are discharged. Like
right.
Like the we talked about the guy in Kansas City, he got discharged in less than 24 hours. So then what happens is basically neuropsych symptom checks, and then to see how you are right now to how you were before concussion, or right now to determine how far it is.
How far away were you from where your baseline? So if you never had that, so our normal population doesn't have a baseline neuropsych test available. So oftentimes you have a bump to the head. It's symptom management, and it's either assumed, well, I was a concussion or whatever, or we'll just see how it goes. Good luck.
See how it goes, and then best you can. General population, just keep track of your symptoms.
Right.
Yeah, because they might not have those resources to the impact, or most likely no one's gonna be doing the baseline test.
Yeah.
Yep.
But if you got a player, they've had a head injury, they've been diagnosed with a concussion, that automatically starts a protocol, right? So in that setting, you now as a provider have a protocol. The player has a protocol.
Yeah.
And who sets that protocol? Where does that come from? Where's that?
That comes from the league.
Okay.
In soccer, that comes from Major League Soccer.
Okay.
And Major League Soccer, they're more like a chief medical officer of the league. So each team has a CMO, but there's above that who decides what kind of protocol needs to go down to enforce those rules. They decide those things, and then here is what that protocol is.
Right.
And they usually share the information with the other leagues like NHL, NFL, or FIFA, or any of those people to kind of, hey, what are you guys doing? What are you guys doing? This and that. Yeah. So then they come up with this protocol, and I don't think it has changed. It hasn't changed the last couple of years. But the return to play protocol is at minimum takes 6 days.
Right. And so that from the league standpoint and from the player standpoint, that return to play, that's really what they're hoping for.
Correct.
Or what they're looking for.
What they are looking for to I guess in a bad way to protect themselves, a good way that I guess player can be safely returned.
Right. So that's the hope, is that it's going to give the player some safety. It's going to give the team some safety, so that things are going to happen.
Yeah.
And we're going to minimize the risk to get re-injured and make sure that they're good to go.
Yep.
That's the utopia, right? That's what we hope happens.
Yeah, that's how I hope happens. And then, I think from my experience, most of the times it happens.
Yeah.
And when they don't happens, we don't really have nothing else.
So that kind of leads into this, because we've talked about this, is that there's some good reasons for that. There's some good things, but we see that's when we see the people is they fall through those cracks. Maybe they pass a protocol, they're back, but that doesn't mean that they're actually ready to, I mean, physically ready to go. They're healed. They're doing well. It just means that they've been able to pass a protocol.
Yep.
So from you probably speak to this from a provider, what is that, how do you manage that in that setting? That was a loaded question.
So if I were inside the organization and I see that someone passes a protocol, but they're on the side, pull me aside, say, hey, by the way, I don't feel good. In me personally, I have an obligation to report that to somebody.
Right.
A lot of times, players don't even do that because
they don't want to, because they want to play too. They're
because depends on what type of player, what kind of career they're at. All those different variables comes in. But let's say someone who's young and then get a concussion and then don't feel good, but that passed the concussion, but this is his last year's a contract, and then he needs to be on the field to get another contract. Those guys will never say anything.
Right.
You just don't. And then the guys who is 32 years old, had all the good careers, and you have a family and kids and just almost out the way. Those guys like, nah, I'm not playing. I feel good.
I need to figure out what to do.
I need to figure out.
Yeah. So it's a very interesting thing to manage, I'm sure, from that perspective.
Yes. And then there's all these, like, in my experience, there's this, not political, but like a narrative labelings that are happening, and then things just get crazy.
Yeah.
Those are the people right now. I'm a consultant comes to me because they don't want to really deal with those things that is happening internally, but they just want to get better.
Yeah. So that's what makes your job now consulting a little bit easier, because you're not managing that.
Yeah.
What do you want to call it, political or not, that different management. So you can actually get to, hey, I actually want to help this guy feel better. Because I know we've had some patients that we've shared, guys that can pass protocols, they can play, right? They can
play.
They're skilled, right? They can play soccer, they can run, perform, lead, do all that stuff, but they can't walk through the grocery store without feeling like they're gonna, pass out or puke, right?
Nope. And it's that's a tough one.
So then, how do you, they return to play. They're doing what they need to do and they're making their money, but we want them to actually feel good. So that's the whole thing. So what sort of things do you feel are from things that from either, assessment or treatment is kind of missed in that kind of early, protocol phase? What sort of things would I guess you can say, what kind of things are usually done for recovery rehab in that setting, and maybe what would be things that you think are maybe missed that could be done in a more meaningful manner? Does that make sense?
Yes. In my experience, traditionally, in looking at associating with teams that I worked with or other teams I have a relationship with, traditional ATCs don't really do much for concussion treatments.
Okay.
If the team has a physical therapist, they will do a lot of, most likely, vestibular exercises.
Balance training,
all that, because most likely that's what their lingering symptoms a lot of times. Mm-hmm. Like when they start running, you go through the protocol. At one point, I feel good, I want to go jog, and then as soon as they start bouncing the body, everything starts shaking. And then protocol wise, okay, symptom of bouncy vision equals to vestibular issues, which means you're gonna stagger stance, and put the popsicle stick in front of it, and you just look at it.
Work on vision therapy, vision exercise, kind of, right?
Yeah, more more trying to be more converge or whatever you want to call
Yeah,
it.
yeah.
But that's the maximum things we will do, and a lot of time ATCs will not really do anything besides like a neck massage or something like that.
Yeah. And we talk, usually there's an associated neck injury. If somebody had it, their probably neck is involved a little bit too, which we feel is a bigger deal than maybe what might be thought of from a concussion kind of standpoint. I know that a lot of them are told just rest. You got to rest until your symptoms go away, right? And there's no real active intervention for rest, right? And I think
whatever the rest means for that player is the rest.
Is rest, yeah. Does that go lock yourself in a room to turn the lights off until your headache goes away? Is it?
Yeah. So that's how they started figuring out, oh, this feels better and this doesn't feel better.
Right.
Which gives us a sign to be able to, oh, okay, that's what's happening. Like you and I will probably know that. But I think clinically, as far as assessment goes, I think the biggest miss that I wish ATC will do is a neck assessment.
Yeah.
Yeah. Not actively, passively.
Yeah. Is the neck able to even handle anything?
Yeah.
And obviously from a PRI approach of what we do, we want to help get that system into a state of rest so that they could actually rest. So that was our discussion yesterday was they're told to rest, but no, if their body's not in a state where they can rest because of neck tension or because of all these other things we might look at, they're not doing activity, but they're not actually resting necessarily. So I think that's from what we talked about. I think that's a big, maybe miss early on would be let's help these guys get into a state of rest easier rather than just letting them figure it out on their own. Because sometimes you might go, okay, well, it's been 2-3 weeks. They're still just, they can't turn the lights on yet. They can't do anything because they're not resting well.
Yeah, I think, like you said, it really even normal clinician doesn't really understand what the rest means.
Yeah.
So I think that's the biggest thing, and it could be from us, it could be neck doesn't move or hip doesn't move or ribcage doesn't move, which means they're more fight or flight, but that's usually not how people look at things.
Yeah. So when we talk this, we have some objective ways to say, hey, if we see these things, we know you're not in a position where you're resting.
Yep.
Objectively, not just subjectively.
Yep. Got it.
Which is nice, right? So, and you said a lot of the treatment that they're going to get early on probably is going to be head neck oriented, visual issues, right? Maybe some tinted glasses, maybe some. I know there's teams that are doing VR work to try to get things limbered up. I mean,
you got some neck collars.
Yeah, neck collars. Maybe, like I said, maybe neck massage if it's stiff or whatever.
Yeah.
But is there much treatment going on below the neck associated with concussion, really, even at all?
Not out there right now. No.
Not until they're trying to return to play, and then it's jog, run, kick a ball, throw.
It's more functional rather than actual clinical assessment or treatment
or intervention.
Interventions, how can their brain works. I mean, clinicians' brain works in a way that how can this guy get back on the field and kick a soccer ball to run and create some type of speed that they used to have.
Can they perform what they've got to perform, right? That's what they've got to be able to do.
It's almost like let them do it, not we doing something for them.
And then when they start to perform, the protocol would be, well, can they do it without symptoms? So who are they asking about symptoms?
So symptoms are usually that symptom check sheet is there every day.
Yeah, and who fills that out?
Players.
Right. Okay. So if they want to play, can they? Right.
All zeros, no problem.
Yeah, because they know if they have symptoms, they're not going to play, right? Or they know what that protocol kind of looks like, right?
Yeah, because it says on there it has to be less than 3 or something like that.
Yeah. So they know, right, what they want to do or what they don't want to do, right? So it's a subjective way to kind of say, hey, we're getting in a good position, rather than having some good objective measurements that say, yeah, you have an ability to ready to go. So I think most of those strategies, it seems like, and whether it's in the soccer world or just general neurologists that see people that were in car accidents, that they're missing that kind of whole body perspective on managing that. So now you got a guy, you've been working with them, or maybe now we're out of that. You're seeing them and they're 6 months out and they're still not feeling good, or you're dealing with those concussions things. What's kind of we know we're looking at that whole body system. What kind of treatment things are you finding is successful when you're dealing with guys that are still having symptoms with concussions?
Yeah. So like right now, if I see a guy like, professional athletes that is, post concussion, 6 to a year, nothing's changing, keep getting worse. I think, still the treatment approach is after neutrality. Yeah. Because they have not been neutral for a long time, probably before even they got a concussion. They're not
most likely
not begin with, because performance athletes are usually very, very extended. So at that point, they really don't have a balance to begin with. They just tighten up their body to be stable. So in that original state, prior pre-existing condition, and get a concussion, and now you're not getting better, it takes a little bit of an extra effort to get back to where they were.
So this is the analogy I used yesterday, and maybe it makes sense to you, and I've used it with some of my patients, as so if you broke a bone, right?
Yeah.
And you didn't set that bone in a good position when it healed, right? You would heal with your bone out of position. So these guys are hurting their heads while they're probably in an extended state. They go into a further extended state where they're not grounded, they're not, neutral, and then they heal.
Yeah.
Right. So to speak. Right.
Yeah.
Which again, now long term makes it harder to get out of that position.
Yeah. Right. And then, those are the people, like, their normal is not a normal anymore.
Right. Yeah.
3 different ways. So
just makes it more challenging to figure out, but you still start with the same thing. And what are we going to do to get this guy?
What are we doing to get this guy in neutral and then flip the switch for them is, sometimes I have to go right away to, like, tease and stuff like that. But I in general, the most successful PRI exercise is, to me, is like a simple modify all four belly lift.
Yeah.
That is somehow a really like a calming position for a lot of athletes. Maybe that position itself is what the opposite of who they are. But that usually really calm down the neck tension, jaw tensions, or headache, or any of that kind of stuff. And then rib cage is going down. And
reestablishes a breathing position. That's
breathing and a cat, and it's very easy to cue, and then PME expands, and then they're like, oh, okay, I feel good. So when they feel that difference, oh, I feel good just doing this, is going to get them out of this, like, almost like a depression hole. Yeah. Like, oh, I finally found something makes me feel better besides medication.
Yeah, just having a little bit of control, and we talked to Ann about that in our conversation.
Yeah.
The second you feel something get a little better, and you're all in.
Brain goes bam, and then that's the door.
Yeah. So breathing is where you start to make sure they get in a position where they can breathe effectively.
Yep.
And then again, before we go into weird stuff, getting them back. I tell people, I get you back on planet Earth. So getting them that sense of ground underneath their feet back.
Yep. Sense of the feel of the ground for athletes, especially soccer player, is somewhat complicated because those guys are feet people.
Yeah, they're into their feet.
They're into the feet, and those guys needs actually proper shoes right away, because those guys usually flip flop, like Crocs, whatever those things are, not very stable. So.
And I would say maybe I'm just thinking this as we talk. They like to feel the top of their feet, the inside of their foot, the outside of their foot, right? That's where they control the ball. They don't control the ball necessarily with the bottom of their feet.
And the bottom of their feet is a cleat, so it's not even
really on the ground. So they have really to get them to sense the bottom of their feet that they have some stability to build off of. I mean, that makes sense. That would be challenging for a soccer player.
Yeah, it's challenging, and then on top of that, if they broke the bone or had a Jones fracture or something like that, or at least
Evidence ankle sprains in soccer players is
and that goes things on top of what's already happening over here, and it may be a little bit tricky to establish a neutrality, but still, I believe that just doing simple breathing will get them out the door at least symptomatic wise.
Yeah. At least being able to say, hey, this guy actually got something that wants to, something different. And again, you've gone 6 months with a concussion and nobody's ever even taught you how to breathe in a way that relaxing, which is, powerful still even in that time. So it's a great go-to, kind of technique to get into. And that's what we talked about was groundedness, breathing. Lori loves to go after a squat, get their quads back loaded up so they can kind of really learn how to regulate pressure from the ground up. And that really turns off the neck. So to be able to go back and look and say, hey, is that neck in a better position? Requires breathing and groundedness.
Yeah. So get the threats away from their brain and they can shut it off.
Right.
Yeah.
Are there any once these guys are kind of in this world where they're a little bit different, they've hit their heads, do you see a lot of patterns of things that kind of tend to return for these guys? Like when you got to manage and then something will happen and something will come back. What's kind of, if you're sending a guy home, hey, here's what you need to make sure you're constantly doing or checking in with to make sure that you can kind of control your symptoms. Do you have things that you'd like to really get them doing?
Yeah. So if I were in an actual team, post-concussion, I mean, there's a pre-concussion assessment and a post-concussion PRI assessment, but I will always check neck and left horizontal abduction.
Okay, yeah.
And then right HGIR. That's it.
Yeah, which basically just tells us, have they let go of their neck? Are they still holding? Are they inhibited with their neck? And if that's the case, it's going to be really challenging for those concussion symptoms to go away. And we just talked two big things. Then you say, if your neck is tight, breathe. What shoes are you putting on? Where are you at on planet Earth? Right.
I made a lot of guys wear certain shoes, and all those things they feel the difference, right? That's the most comfy shoes I've ever had. I'm like, it's just basics, dude. And like, okay, and then that spreads out, and then 5-6 people still wearing it. But those are the things that they need to be provided to the whole system approach. I don't really check the hip because the soccer player's hip is so trash that it just doesn't really give me a lot. So I just hear above and then educate them. Hey, you came back training for 60 minutes. You feel good, but this is tight, buddy. What do you need to do? Yeah. And that could be physical therapy exercise, or that could be going to the gym and then just do little alternation exercise and then recheck and then, hey, good to go, buddy. Go home.
Yeah. But you got some objectivity to it, and then they've got some tools and things that they can go through. And once they realize that they're managing their whole system, again, gives them control, gives them things that they can do, and actually is effective in rather than just, hey, go home and shut the lights off and don't look at your phone.
Yeah. So that's like more our own protocol, right?
Yeah.
Objective protocol we have to be able to go after. So what they feel and then what we able to see on objectives kind of match up.
Yeah. So what do you think is the biggest thing that's preventing that kind of an approach from being more, I don't want to say mainstream, but accepted as, hey, this actually works. Why aren't more people doing it?
I don't know. I mean, certainly that's a lot of work.
Yeah.
But also, I think it's just like the education we all go through just doesn't doesn't provide that.
Which is why we're talking. I just want people to know that there is more the more you can do, right?
Like,
You do what you know. Not that like I said, the protocols aren't necessarily bad. That's what's out there, but I think there's ways they could improve it. I also do think that, and we see this with PT too. Well, why don't all PTs do this? Well, it's more work.
yeah.
You got to think a little bit, which is okay, but some people just don't want to think that hard.
Yeah, I don't want to think that hard, and it's
And the thing about a protocol is it can be carried over multiple times with multiple different people, right?
Yeah, because it's easier that way.
It's easier that way rather than, hey, I'm going to look at this guy. This guy needs something a little bit different than this guy needs. We have the same kind of overall framework we're looking at, but this guy might need something a little bit different. Maybe this guy actually does need to go somewhere and get something for his teeth. Maybe that's a different sort of a thing.
Yeah,
right?
So team environment is hard to do that individualization.
Right.
Like there's a big debate on is it good or bad because they don't want to change things because they're tracking all this like
there's data analysis and there's
data analysis and all that, and in order to do that, everything needs to be standardized. Otherwise, the data is not going to be accurate. So in the medical side, you also want to create that, but also be able to know this guy is different than this guy is different than that.
Yeah. So we call that you either have evidence-based practice, right? You have to have the evidence, right, to practice, and that's such a big term, and I know in the PT world, but we like to look at practice-based evidence, right? We know that this works because we've done it, and we have the evidence behind it, but the evidence of why we're doing what we're doing is because it works, right?
Yeah.
So, but it's hard to get a protocol based off of that because it's individualized. So that's why there's the pros and cons between. We have to have some standardization and some baseline, but hopefully some autonomy with people that understand how to manage people from an individual basis. And I think what you're doing gives you more freedom to do that.
Yeah, freedom to do it, and then it's really up to clinicians. Like I don't want to say care. I mean, do you care about it?
Yeah, of course they care, but in what way, right?
In what way? And are you curious about learning more stuff to be more not accurate, but more effective approach to the patient care? Right. We talk about best practice all the time. Like, what does it mean? Yeah. Like, this practice doesn't work, or this practice that works.
Right.
So, it's really a different way of thinking about it. But to me personally, like, I would understand that each player is differently, and then they'll create their approach routines differently, so that they're comfortable with what you're providing to them.
Right. It's the same thing in the PT world. There's lots of approaches, and there's lots of concussion, clinics, and there's even here in Lincoln we've got a great place. They have a really good concussion clinic, right? And they've got PT and they got vision therapy and that kind of stuff, and it works great for some people, but not everybody, right? No. So because they don't know and don't do what we do, and so we see people that fall through those cracks again because nobody really ever got them in a good pair of shoes, or nobody really looked at their bite or whatever it would look like. So and I just know you do good work, and we get to work together on those people that get to a point where they need a little extra help. So having guys that work together and other people on your team is a big piece of it, and that's where we've been able to meet. And so do you have a thought when hey, when you need to phone a friend? I got you on speed dial, right?
Yeah, you text and call Stacy, and there you go, you're in.
Yeah.
You need Torin.
Yeah. So and you have, again, that's where having the framework, right? We got to keep this system in a good position. You can't just say, well, let's keep working. I got to get this. I'm not getting it. We got to get other people on board and do it. Yeah. Same thing. So that just gives us a way to go. So I think the last thing I wanted to say, just, do you have any advice for either maybe athletic trainers or people that were thinking, I want to do better at managing concussions, or advice for people that have maybe had a concussion, don't understand what to do next? What would be your big takeaway advice, either for trainers or for patients?
Yeah. So for trainers, I think if you really want to learn about concussions, I think you really need to learn something outside the box. Like it doesn't need to be a PRI, but it's more like a systemic approach. Like it could be a DNS, it could be anything else, but just to learn something you didn't learn at school.
Right.
And that will kind of give them a little different perspective when nothing works.
Right.
And I think
learning.
Yeah, that's like how everything starts, and that's how I started. Okay, this cannot be the end of the knowledge. There's gotta be something else, right? And otherwise, like every ATC does the same thing. Like that's what you know is what you know. What you don't know is what you don't know.
Right.
But I think that'll be where I would start if someone's curious about managing a concussion in a better way or something new. So
yep.
Yeah.
Learn, and then if you you got a family member, they call you up and say, "Hey, Yoshi, I just had a concussion. I don't feel very good. What should I do?"
Well, I'll be like, it really depends. But like, hey, where do you live?
Yeah.
And let me go Google the state in the provider PRI, and then you go see that person.
Yeah, find somebody that knows what they're doing. Get you in a and sooner rather than later. Like I said, I think taking an active approach to that rest phase, I think, is a valuable thing for people, because I wish that message got out more, because again, we see them months and years later, and I think we could have helped a lot sooner if we were able to kind of get into that phase a little bit better.
Yeah. So like, I mean, we have a internet, social media to go by. People make a lot of information and guidance.
Right.
Yeah. So I'll be very careful with that if you're non-medical people. But usually my suggestion, if I get a phone call from somebody, hey, do you know anybody? I'll be the first one Googling who's a PRC.
Yeah. Find somebody that you trust, that is in the area.
At a minimum, I wouldn't go see based on your symptom. I wouldn't go to that kind of provider like optometrists, ENT, all those people to start educating different things to you.
Yeah.
That just gets things very, very complicated later on.
Yeah. So, and you probably will see those providers, and it's good to rule out that there's nothing major going on, right? But don't then, stop. I tell people, just if you're not feeling good, keep asking questions. Don't settle for, hey, just rest, it'll get better.
Right. So, orthopedically, I guess we rule out everything possible, right? And then if you don't get better and the symptoms,
be proactive.
Yeah. Proactive, find the providers, and then hopefully that person will guide you. But I will guide anybody for sure.
Yeah. So, all right. Appreciate you. It's a good conversation. If people have questions, again, this will be a video. Leave a comment. I'll look at him here, or we'll get off to Yoshi, and he's easily accessible for all of us. So if something comes up, we'll do it.
Sounds good.
All right. Thanks so much. Appreciate you.
Okay.
Have a good one.
Yeah, you too.